We'll start over. Hi, welcome everyone. My name is Maureen Martin and I'm the Programs Continuum Coordinator for CAN-DO Multiple Sclerosis. I want to thank you for acting on the belief that you are more than your MS by attending tonight's webinar, Bladder Issues and MS with Pat Kennedy. I want to start tonight's program by just talking a little bit about CAN-DO Multiple Sclerosis. CAN-DO MS, formerly the Huga Center for MS, is an innovative provider of lifestyle empowerment programs for people with MS and their support partners. We are the start of a whole new way of thinking about and living with MS. A national nonprofit organization, we empower people to move beyond their MS by giving them the knowledge, skills, tools, and confidence to adopt healthy lifestyle behaviors, actively co-manage their disease, and live their best lives. Our renowned programs have helped thousands of people with MS reclaim their dignity, control, and freedom, and transform their challenges into possibilities. CAN-DO MS recently launched our new website, www.mscando.org. Please visit our new website where you can register for upcoming webinars. You can listen to our archived webinars. You can check out our upcoming CAN-DO MS Lifestyle Empowerment programs. You can share your CAN-DO promise. And you can learn ways you can contribute to or get involved with CAN-DO MS. So just a few housekeeping items before we get started. As I said at the beginning of the call, we have about 70 people on the line with us so far, and looks like more are logging in and calling in as we speak. This presentation is being recorded, and it will be archived on CAN-DO MS's website. You're more than welcome to view the presentation again, and if you miss one of our upcoming webinars, you can find the archived version on CAN-DO MS's website. To ensure good sound quality with no background noise, all of the participants are in listen-only mode for the live presentation. And although your phone lines are muted, you still have the capability to submit questions to Pat. And we encourage questions at any time throughout the presentation. Feel free to type your questions using the chat feature located on the left of your computer screen. So you should see a box on the left side of your computer screen that says chat. And to submit a question, type in the small box that says Chat with Presenter. Pat will address as many questions as time will allow at the end of her presentation. So the job of the live participants tonight is to, number one, submit your questions throughout the presentation. Number two, complete the evaluation at the end of the webinar. 3, review the webinar schedule and register for the other CAN-DO MS webinars. We would like to thank Novartis Pharmaceutical Companies. The CAN-DO MS webinar series is sponsored by an educational grant from Novartis Pharmaceutical Companies. So we have a great speaker tonight to talk about bladder issues and MS. Pat Kennedy serves on the board of International Organization of MS Nurses and has been working in the field of multiple sclerosis since 1987. She is the nurse educator and a programs advisor for CAN-DO MS. In addition, she serves as a clinical consultant for the National MS Society and is a member of the Client Education Committee. In Colorado, she serves on the Clinical Advisory Committee for the National MS Chapter. And she's also active in the Consortium of MS Centers and is on the editorial board of the International Journal of MS Care. So before we get started tonight, let's do a quick survey to see who is on the webinar with us tonight. So I just put a survey up on the screen. So you can just submit your answers. We're asking if you're a person living with MS, a support partner, a healthcare provider, or other. So we'll just wait a couple seconds and let everyone have time to submit their answers. All right. So we have almost everyone is a person living with MS. It looks like maybe one person on the call is a healthcare professional, so that's great. We appreciate everyone being on the call. And with that, I will turn it over to Pat Kennedy.
Thank you so much, Maureen, and I'm so happy to have you all on the call tonight. We, working at CAN-DO MS, we know that the symptoms caused by MS can detract from your total health. That's what we're all about, is helping you with your total health. Tonight we'll discuss bladder symptoms that you're having. And by doing so, we hope to contribute to your overall knowledge about this subject, and also to give you some tools to help you seek management of these symptoms if that is an issue for you. Excuse me. So that's why we chose this topic, and we know it's a fairly commonly experienced symptom in MS, and we just wanted to give you a bit more to work with so that you can take charge and empower you to kind of take hold of this particular symptom. When we think about bladders, I don't think most of us in life have spent a great deal of time thinking about our bladders. We were potty trained a long, long, long time ago, and we didn't have to think about it much after that. We, got the message that our bladder was full, we had to go to the bathroom, we would do so, then we wouldn't think about it again until the next time that the bladder gave us the message that it was time to empty. We just never thought a whole lot about how does this whole mechanism work. We do know that in our lives there have been times when we've either had to go more or we've had to go less. During pregnancy, women have to go a lot more often. When you drink alcohol, when you increase your fluid intake in general, when you take certain medications like diuretics. And we know that if a person has a bladder infection, they tend to have to go frequently. And these are things you may have experienced over your lifetime. At times, you also know that you go less often when you're dehydrated, when you are in a lifestyle that sort of requires you to be one place and not be in others. And I pick on teachers and nurses for this, but of course it applies to a lot of people. But, when you're in a classroom full of kids, you don't always just have the ability to get up and run to the bathroom. And nurses sometimes in a busy shift don't have time to go often to the bathroom. So lifestyle-wise, we have times when we just don't go as much as others. And also, there are some medications that will cause us not to be able to go as often. MS, though, as a disease, as a neurologic problem, can also affect your bladder function. Now, for some of you, you're probably going, oh, great, well, I already knew that. But the point is that not everyone does know this, and so that's why I bring it up. When we talk about bladder function, we know that it sometimes can be the very first symptom of MS. I did have a patient once who presented at family practice with what she thought were frequent bladder infections over and over and over again because she would be voiding so often. And ultimately what happened was the family practice physician said, I think this is not frequent bladder infections. I think this is something else. And indeed, it was her first symptom of MS. Bladder symptoms can also be intermittent. In other words, people can have times in their lifetime with MS when bladder function is affected, and then many times when the bladder functions just fine. And isn't that true, though, for so many of your MS symptoms? They come and they go. The frequency of bladder issues with MS over the lifespan of having MS is about 85% of people with MS have some bladder issues. And that's a huge number of people. And so this is a topic that is always quite needed and popular in a sense that so many people experience this symptom, and some people don't know that it is, in fact, a symptom of MS. So why do you need to know more? I mean, you're doing whatever you're doing now. Why isn't that enough? Well, lots of reasons. and I think it's important to tell you what those reasons are. First of all, for yourself, for your own personal life and quality of life. Bladder problems are inconvenient and they're uncomfortable. You have to admit that when you have issues in this area, you're just not quite as comfortable getting around in your world, and you're always worried about this bladder and what it's going to do next. It can be intrusive in your lifestyle and actually cause you to drop out of things because of the fact that you're just not too sure if you can get through some of your activities because of the bladder. Bladder problems with MS also can be the root of bladder infections, and bladder infections are not fun to go through, and for some people bladder infections can progress and become kidney infections, and also bladder infections that become kidney infections then can affect the functioning of the kidneys themselves. So this is a much bigger issue than just having to find all the bathrooms in the grocery stores and the shopping center. This is also for your ongoing health over a lifetime, and that is not directly related to MS, but it certainly would be related to a bladder that has caused these kinds of issues. Bladder problems can interfere with self-esteem. I don't know how many of you on the phone are needing to wear some sort of protection, but you know it just eats away at that comfort level that you might have had previously where that wasn't an issue. Bladder problems can certainly cause isolation. People are afraid to leave their house because of the fact that you do have to know where all the bathrooms are, and it just sometimes is easier not to leave, and that's what I call isolation. And finally, bladder problems can be silent, and I mean that in two ways. Those around you may not have any idea that you have a bladder issue. So it's silent. You're suffering greatly, but those around you may not understand that. So, there's that but you look so good problem. And the other one is it's silent in a sense that if you get to the point where you have infections, they aren't always symptomatic. And so you could be kind of sitting on a time bomb with a bladder infection that's sitting in the wings and you're not even aware of it. So let's talk about all this so you can move forward and take care of it. The good news about bladder issues is that most of the symptoms can be managed in one way or another. It does take some trial and error, so it isn't as if you will go into your physician's office and say, this problem, and there will be one answer to your problem. It's going to take some digging into it and finding out sort of what else is going on and looking into it. Bladder symptoms also can change over time. So if you're early in your disease, your bladder may be behaving in one way. If you've had MS for a while, the bladder now may be behaving in another way. So if you were checked out for your bladder early on in MS and now it's many years later and your bladder isn't responding to whatever you started using years ago, it could be that you need to be rechecked out because the bladder itself may change its function over time. So it's important to stay on top of it and to realize that it may change. And your lifestyle also may need to change some. You may need to make some adjustments because of a bladder that is out of control for you. And, whether that's in an office setting where your desk needs to be closer to the bathroom, or whether that's on a trip, you just make sure that you plan stops along the way that are a little closer together. Whatever the case may be, there may be some changes that need to be made with lifestyle issues. So I'm going to show you now the anatomy of the urinary tract system. And I'm starting off up here with the kidneys. Now, if you look where I'm pointing for the kidneys, you'll see that they're quite high. They actually sit under your ribs. So I just the other day had a patient say something to me about, oh, well, I have this low back pain. And I said, well, in all likelihood, that isn't related to the kidneys. You know, it may be related to something else important, but it's not the kidneys, because the kidneys are really quite high up in our bellies and under those ribs. And then we have the tube that goes from the kidneys and drains the urine from the kidneys down into the bladder. And those are called ureters. And again, they're just merely a way to deposit those liquid wastes from the kidney into the bladder. The bladder is a muscle. It's called the detrusor muscle. And the bladder is really a reservoir for that urine. And the bladder is under control of the nervous system. At the bottom of the bladder are sphincters or valves that keep the urine in or let the urine out. And then the tube that goes from the bladder to the outside is known as the urethra. And just moving my slides here. So now I want to show you how the nervous system plays a role in bladder function. And the first one we'll do is normal nervous system, normal bladder function. And I'm going to show you that the way this all works is as the kidneys have dropped the urine into the bladder, then we end up with a bladder that is filling. Now I have to go back here, sorry. So now we have a bladder that is filling with urine. And you know, the bladder can fill with urine to about half a cup to a full cup's worth of urine in a normal situation. And then you get the message. And the reason you get the message is that messages go from the bladder through the nervous system to the spinal cord, and then go up the spinal cord to the brain and let the brain know that, in fact, the bladder is filling. Now, if you're on the highway and you're driving and the exit is still 10 miles away, your brain knows that this isn't the right time, and it sends the message back down through the spinal cord and then again out to the bladder and tells that bladder to keep holding on to the urine. And so the sphincter will stay shut, the bladder will continue to stretch and hold more urine, and you'll get off at the next exit and you'll get to the bathroom, and at that time then the brain sends a message down the spinal cord and out to the bladder and tells the bladder muscle to squeeze and tells the sphincter to open. So you get that, the synchronized working of the bladder with the squeezing here and then the opening of the sphincter down here. Then you go back to not noticing your bladder anymore, just as I said in the beginning, not something you think about all the time. So showing the next slide here. In this slide, what I'm showing you is what happens when there is abnormality in the nervous system and what it does then to the bladder. And the bladder still fills as it did before. Messages still get sent to the spinal cord, and they start to go up the spinal cord. But because of these areas that have myelin damage, whether it's in the spinal cord or whether it's in the brain, those messages may not get all the way up the spinal cord to the brain. And when that happens, then the brain is not getting the message, so it doesn't have that control to then send the messages back down telling the bladder what to do. And so that's how MS affects the function of the bladder. And I'm going to go through with you all the different permutations of that. What different kinds of problems will you see when there is damage along the spinal cord and the brain as far as bladder function is concerned? So we have three kinds of bladder dysfunction. And we have one that involves the storage of urine. We have one that involves the emptying of the urine, and then we have one that's called combined. And each one of those are slightly different, and it's hard to know just by talking to someone exactly which one they have. But I'm going to make an attempt to tell you what to do about recognizing what may be going on with you. The first one, the storage dysfunction. What this means is that usual ability of that brain to be the smart guy and to manage the filling of the bladder is lost, because probably of some lesions in the spinal cord and or the brain. The bladder then acts a bit like, and many of you can recognize this, acts like a baby's bladder. And what happens with babies is, you feed a baby formula, and before long the diaper's wet. You feed a baby formula, the diaper is wet. And that's because myelin is not fully formed in the spinal cord. And so the messages don't go to the brain. The brain doesn't have the ability in an infant to control that emptying of the bladder. Well, picture that in yourself. If you have some damage along that pathway, what may be happening is the message may be going to the spinal cord, but there's a reflex at the spinal cord. And the message will go to the spinal cord and reflex back to the bladder and say empty. And so those of you who have that problem will probably find yourselves voiding, every 15 minutes, 20 minutes, half hour, 45 minutes, but very frequently. And this is the reason why. And so it is, in fact, a problem, as you all know. And what we see as far as symptoms are concerned is that you experience what? Urgency, frequency, and sometimes urge incontinence. So when you get that gotta-go feeling, and you're on your way to get to where you're going, you may dribble or have a loss of some urine along the way. The one thing that stands out, though, is there generally is not a long history of urinary tract infections in a person who empties the bladder frequently, because when they do, they typically empty it well. And so it is an empty bladder. There's no urine left over in the bladder to become infected, and so you typically don't get urinary tract infections. So that's what we see symptomatically with that kind of a bladder. So how do we diagnose this? Well, we can start certainly in family practice. We can start with possibly gynecology. You can start also with your neurologist. And we start with a very careful history. We ask all the right questions and listen to what your history of bladder function is. That gives us a lot of hints. We would, if you came in and said, I'm having to go frequently, we'd have to also make sure there's no infection going on. And so we would definitely check for a urinary tract infection at the same time. When possible, in the ideal world, the next thing we would do would be measure what we call a post-void residual, which means that through ultrasound generally, we're able to scan the bladder. So we will have a person go into the restroom, empty out what they can from their bladder, come back to the exam room, and we'll ultrasound. And if the ultrasound says, yes, the bladder is in fact empty, then we're going to make a big leap of faith here that what's going on is it's a failure to fill kind of bladder. And at that point, we can say, all things being equal, this is a safe time. We can try some of the treatments that are available for this kind of bladder. And you'll see on this list on your screen a number of medications that are used for bladder problems. Now, it's a very lengthy list. I have to tell you, when I started in MS, there was one thing on that list, and that was oxybutynin. But now we have a number of things that we can use for bladder issues for the person who empties well but has to go often. And what these drugs do basically is they help that bladder muscle to relax, and so it holds more urine before it absolutely has to squeeze that urine out. And so it gives you time. to get to the bathroom without loss of control. It may give you time to do more activities because it may stretch that time from one going to the next going. So the medications really have a good purpose. And, you look at this long list and you think, oh, well, that shouldn't be too tough. And the problem is that all these medications work similarly, but they certainly don't work the same in every person. So you may have, again, some trial and error trying to find the right medication with the least side effects for you. But again, this is for the person who empties their bladder well, just empties it too often. If a person is having frequent nighttime voiding, we can certainly try the other medications first because they're simpler. And if they don't work for this particular problem, we may use something called DDAVP or desmopressin. And what that does is it doesn't affect the bladder at all directly. It actually works with the kidney by reducing the amount of urine that the kidney makes during those nighttime hours. It'll make it up the next day, so it's not harming anything long term. But there are side effects to it. But sometimes, if you're getting up 6-8 times at night, it might be worth it to take something that might help prevent that happening for you. And remember that, again, all these medications have side effects, and you may have to try several before you come across the one that works absolutely best for you. So other things you can do besides medications are, one, you can learn to manage fluids. I'll bet you're doing that already. And people tend to stop drinking when they have bladder problems, because why would you drink if you know that that's going to go right into urine and then you're going to have to go to the bathroom again? So people tend to drink less, or in some cases they don't drink at all to speak of during the day, just enough to get medication down. And what's interesting is that if you drink less and less fluid throughout the day, what it does is make your urine more concentrated. And when the urine is more concentrated, it irritates the bladder and makes the bladder want to empty more often. The second thing that may happen is that all of us in today's world, it seems, are carrying around water bottles of one kind or another. And if you have a bladder that is not functioning properly and you have your water bottle with you and you sip it throughout the day, what's going to happen is you're going to have to urinate more often. So you really are in a better place if you would drink a slightly larger amount less often. So no sipping, but in fact drink maybe a quarter to a half a cup at a time and do it less often. And that way you're putting more fluid at one time into the bladder, so the bladder will empty more fluid at one time instead of your having to go more frequently. Another thing you can do for yourself is time how often you're going. If you know, keep a little history. If you know that you tend to go every hour and a half or every 2 hours, one thing you can do is to time yourself, and instead of going every 2 hours, go into the bathroom at 1 hour and 45 minutes. That way you eliminate that urgency and that need to run to the bathroom. You can also see there are physical therapists who are specially trained in doing bladder work, helping to strengthen those pelvic floor muscles. And you might be a candidate for that. That's something you can certainly talk about with your physician. But it does work well for some people. Also, there are some dietary changes that you may need to consider, such as limiting caffeine. And I think all of you know that if you drink caffeine, it's probably going to make you have to go more often. NutraSweet, interestingly enough, that particular product does seem to irritate the bladder and cause people to have to go more often. And alcohol. I mean, if you've ever had a beer, you know how quickly it seems to go through you. So if you're having a problem with your bladder, you want to make sure that you're paying attention to those sorts of fluids and substances that you're putting into your body. So if your bladder has an emptying problem, what this means is several things. Lesions in the brain and the spine can cause sort of lack of coordination of the bladder muscle, the detrusor muscle, and the sphincter at the bottom of that muscle that keeps the urine in or lets the urine out. And so instead of working in a coordinated fashion, they begin to work against each other. A second thing that can happen is that a sphincter may open and relax and let some urine out, but then it closes too quickly. And when that happens, then your bladder is not empty. And the third thing that can happen is the sphincter can actually become, the word is paralysis, but it basically stays in the shut position. And so a person who has any of these three problems is going to have some issues with getting that bladder empty. So what are the symptoms of this? Well, frequency. It sounds awfully familiar, doesn't it? Frequency, urgency, and urgent continence are on the list just as they were with the other kind of bladder. And so this is why you can't sit and say, oh, well, I have that kind of bladder. We really need to look into this further. But a person who can't empty also has, sometimes, incontinence without urgency. So all of a sudden, their bladder empties because that coordination piece wasn't there. They may also have hesitancy. They know they have to go. They've made the run to the bathroom. They get there. They sit down or they stand up in front of the toilet, and they can't get the stream started. And, it's a very uncomfortable situation, and it happens more frequently than you know. Also, some people like to come in and say, boy, I can hold my urine all day long. I go when I get up in the morning, and I make myself go when I go to bed at night. Well, what's happening there. You've got someone who isn't able or not getting the messages to let that urine out, and that's going to be a setup for bladder infections and stretching of the bladder and other problems. Person might not feel empty. They may go, think they're empty, stand up, and go outside, and 2 minutes later, oh, geez, I have to go to the bathroom again. So they go back into the bathroom, and this is that not feeling empty. Some people report that they have a very slow stream compared to what is normal for them. And there usually is a history of urinary tract infections. So this is a big clue for us that there's some emptying issue going on. So again, how do we diagnose this? Well, we do exactly the same thing. We get that history, we check for infection, and we try, if we have the capability of measuring how much urine is left in that bladder after a person has gone. And here's where the difference begins, because you might end up with some urine left in the bladder, but it may not be a huge amount, and I call that a low post-void residual. And if a person has that, then they may be able to manage this issue by such things as double voiding. Double voiding means that you go the first time with intent, you step away from the toilet, play with the guest towels or whatever, and then go right back, sit back down, and go again, or stand up in front of the toilet and go again. It's a bit like booting your computer, rebooting your computer. You've had to go, you go in, you sit down, you stand up, you empty, and so your brain is telling your bladder, go. And then you step away and you do something else. Now your brain is telling your legs, do something. And then you come back to the toilet and you try to go again. So you have rebooted because now your brain is telling your bladder again to try again. And so double voiding is very helpful for people. I've had patients triple void at times because if they can manage their bladder that way, that's certainly an easier solution than some others. Time voiding, again, you want to make sure that, if you kind of are going a long period of time between going, then you might want to sort of set your watch to make sure you go every 2.5 hours or 3 hours. Just remind yourself, I'd better get in there to the bathroom and go, because you're not getting those same messages. So you have to kind of set something up to tell you to get in there and go. And fluid management. And again, you can sort of time what you're drinking and manage your fluids in that way. And if you're going out, you want to kind of hold fluids before you go. If you're in the house for the day, you want to time it with when you're going to be nearer to the bathroom, etc. So those are things you can do if you are retaining some, but it isn't a large amount. If you are, though, retaining a larger amount of urine, now we have a bigger problem. And you can still do those things I just talked about, but sometimes we try medications, such as some are listed on your screen, and what these medications do is they work on the sphincter. And they allow that sphincter to stay open, relaxed, I should say, a bit longer, so you have a better chance of getting urine out of the bladder. Now, not all physicians think that that's a way that they want to go, but it is a suggestion, so you can take that up with your physician. If these things are not working, then it is time now for you to see a urologist. And urologists have then the capability of examining your system more thoroughly and finding out exactly what it is that's not working so that the right suggestions and the right interventions can be made. Ultimately, what may happen is that if you have a bladder that simply, no matter what we've tried, isn't emptying all the way, you're getting more bladder infections, you're having more problems with incontinence, what we sometimes will do is use those medications that relax the bladder, even though that's counterintuitive. You have a bladder that isn't squeezing well and emptying well. But if you use one of these medications, it will relax the bladder so you don't feel uncomfortable, and then we add intermittent catheterization. And if you're on the phone with me right now and this is something that you've heard of before and there's no way you're going down that road, or if you're doing intermittent catheterization, at least you know what I'm talking about. But the intermittent catheterization certainly on the outside doesn't sound like anything anybody wants to do, but I can tell you from many years of caring for patients that once a person has made up their mind that they can and will and should do this, it changes their lives. So it's not the worst thing in the world that can happen to you, and it is something that would be a solution to a problem. If you go to see a urologist, again, I told you they can more thoroughly evaluate the cause of your symptoms. And they're also going to look for, is this something else? Remember that with MS, we often wear blinders, and everything that's wrong with a person with MS must be due to the MS. And in fact, there can be other issues. So a urologist will, in addition to looking at the bladder, they're also going to do a pelvic exam for a woman to make sure that anatomically that bladder is sitting well, that there isn't pressure on the bladder from something else gone awry in the pelvic area. And for a male, a prostate exam is necessary. Prostates become enlarged, and when they become enlarged, they put narrowing on the urethra to the outside, and so men with prostate issues have many of these same symptoms. And so we can't just say, oh, well, it's got to be the MS. It may, in fact, be the prostate. So that will happen during that urology visit. And then the urologist will do urodynamic testing, which is fairly involved testing of the bladder and the nervous interventions of the bladder. And not pleasant testing, but if it gives you the answers that you need, we can avoid problems later on. So that's what will happen when you go to see a urologist. Now, when a person has combined dysfunction, what this means is there is that lack of coordination between the bladder muscle and the sphincters. And normally, when the bladder empties, remember that bladder muscle squeezes, the sphincters open, and the urine flows out. But in the case of a combined problem, generally what happens is the bladder squeezes to push the urine out, and the sphincters squeeze to keep the urine in. And so we have a real problem here because a person feels pretty uncomfortable because the bladder is trying to get rid of the urine, and also uncomfortable because nothing is coming out. And so this is a combined issue. And the symptoms of this look awfully familiar, don't they? The urgency and hesitancy that you've heard before. There may be a more constant dribbling, and that's because there's so much pressure from in the bladder, and sometimes some of that urine will dribble out even though you're not able to completely void it out. At times, that sphincter will just let go, and there will be a large amount of incontinence. And we do very often see bladder infections occurring in somebody with this kind of bladder. So how do we manage it? Well, as I mentioned just in previous kind of bladder, a combination of medications and intermittent catheterization is used for this kind of bladder. Now, it could be that we might, in fact, consider an indwelling catheter, and I know that most of us have heard that, that's really not a good thing to do. And it isn't certainly something that we choose to do on a regular basis, but there are times when it isn't a bad thing to do. And I'll talk a little bit more about that in just a minute. Also, people may, for the dribbling, may use absorbent pads in their clothing for extra protection. And in some cases, people use that as a way to manage this bladder. They use the toilet when they can. When they can't, they know they have the pad there. You just have to make sure, if that's what you're choosing to do, that you change that pad frequently, or whatever protective device you're using, you change it frequently so that urine is not being held against the skin, because when your skin is frequently wet from urine, it causes irritation, and at times it can cause skin to break down. So you want to make sure that you are changing those frequently. Oops, I'm sorry, I have to go back one. Something else I wanted to talk to you about is that when we have someone who, let's say, is more disabled, and getting from a wheelchair onto a toilet either is a lot of work for the person with the disability, or it's a lot of work for them and their caregiver. Sometimes there comes a point in that situation where it is helpful to have an indwelling catheter, because we have to save the health of the person who is helping, and we have to save the health of the person with MS. And so even though infections may occur with indwelling catheters, when you're looking at the total list of risks and benefits, sometimes the catheter wins out. People have also said to me that if you're doing intermittent catheterization, that there's probably going to be an increase in infections with that, and that research has been done on, and they actually show that if it's done well, it's a clean procedure, it's not sterile, and if it's done well, that infection rate actually goes down, because you're able to actually empty that urine out of the bladder completely, and so the risk of infection goes down. But you'll have to be taught how to do that, and learn. There may be an infection or two in the beginning because you're learning, and you're probably touching some things because you're just in the process of learning. But the point is, over time, the infection rate actually does go down. So that's a good news thing. And then some up-and-coming treatments. And maybe some of you in this audience are already doing this, but there are some studies going on, and some places that are doing this just as part of their practice. The use of Botox, which is botulinum toxin, same thing you use for the wrinkles on your face, but Botox injected into either or both the external sphincter, or that little valve that holds the urine in, What Botox does is it kind of paralyzes, as it were, the muscle so that it relaxes the sphincter a little bit, allows more urine to come out. And also in a person who has an overactive bladder and it just wants to contract all the time, if you put Botox into that bladder muscle, you may have lessening of that contraction all the time. And so this is being used successfully in many cases. Some people haven't had so much success with it, but it is something that's out there. There also can be electrical stimulation of the sacral nerve, and there can be a surgically implanted device to help the bladder store and empty more effectively. If that is implanted, however, it means that you can't have an MRI, because that's one of those things in your body that doesn't do well with the big magnet of an MRI. So somebody with MS would have to think about that very carefully. You know, data about some of these up-and-coming things and availability of some of these things is you know, somewhat limited. I mean, I think we have good data, but there isn't tons of it. But I think it's something you really can talk about with your healthcare provider, and they in turn may send you to a urologist to have that discussion. But you know, I've had patients over time that have really been distressed with their bladder problems, and I would encourage any of you who are also experiencing that frustration to take it to the next step and talk with someone about that, see what the absolute best treatment options are for you, and then get on them. So, in fact, you won't be suffering with as much difficulty. So bladder issues need to be discussed. They're not something, one, to be embarrassed about. They're not something that, oh, well, I've had 5 kids, so that's why I'm having problems with my bladder, or it's probably my prostate, it's probably not the MS. But when you don't talk about this and when you don't deal with this, what you end up with then is a decreased quality of life. And even more importantly, really, is an issue with your kidney health. And if we have damage to the kidneys and you become sicker, that's not getting you anywhere. So it's a quality of life issue and a health issue, so worthy of discussion. So at this point, I'm going to take questions, and I'd love to hear what you all are thinking about and what kinds of questions you would like to ask.
That's great, Pat. Thank you so much. I'm going to kind of ask the questions in groups to kind of keep the topics going. The first couple of questions are about catheters. And one question is, are intermittent and self-catheterization the same thing?
Intermittent and self-catheterization are the same thing. Intermittent means that a person will catheterize themselves at different frequencies throughout the day. Some people can get by with catheterizing first thing in the morning because there's a larger amount of urine in the bladder in the morning, and last thing at night, and that enables them to sleep through the night. And then during the day, they're able to void well enough that they don't need to catheterize during the day. Other people, however, may have enough difficulty voiding during the day that they may need to catheterize during the day as well. And that frequency will be partially talked about with your healthcare provider, but also partially by you, because you'll know the comfort level that you're having. And some people will say, well, it's either 3 times or 4 times or 5 times, depending on what I'm doing, what I'm drinking, how I'm out and about and that sort of thing. So that's the intermittent place. The self-catheterization means that most people are in a position where they can learn how to catheterize themselves. But there are some people that, because of other symptoms like tremor perhaps or weakness, may not be able to catheterize themselves, and that may be done by someone else. But generally it is considered self-catheterization.
Great, thank you. The next question along this line, does using a catheter mean that I will never be able to empty my bladder, quote, normally?
It does not. People, and you know how I said in the beginning that symptoms of bladder problems can come and go in MS, and there are times when you're having more difficulty getting that bladder empty, you have to catheterize at that point. There are other times when it's not as big of a problem. So at times you can, at times you may not. It could be there are some people, though, that get to a point where the bladder, it isn't that you've been catheterizing that makes you have to keep catheterizing. It's that the function of the bladder and the sphincters is just affected enough that the ability to function normally is just not there. And so that individual may have to catheterize from then on.
Great. The next questions are about nighttime urination. So one question is, how many times is normal for urinating at night?
That's a really good question. Depends on your age somewhat. Anywhere from, a younger person, if they have to get up once at night, that's not uncommon at all. If you've been out drinking or you've had a lot of things that day in the way of fluids, you might have to get up twice. To have to get up, and as you get older, you might have to get up 2 times in a pretty normal fashion. But when you get much more than 2 to 3 times at night, that's abnormal.
Great. Kind of along those same lines, when taking a medication for bladder frequent urination during the nighttime hours, when is the best time to take that medication? Or is it dependent on the specific medication?
Another really good question, because it's different for many of the medications. There are medications on that list that are very short-acting. Medications like oxybutynin, for instance, has a 4 to 6 hour window of working. So it's very important that you take that medication kind of on a schedule so that your bladder doesn't have periods where it doesn't have any medication on board. In the old days, when that's all we had to use, people would, take it, their bladder would be okay, and then the medicine would wear off, and then they'd have frequency, and then they'd take another pill. I mean, it was a problem. And then they came out with the longer-acting medications, and many of these will act for 12 hours. Some might not make it quite the whole 12 hours. They may only make it 8 hours, but each medication has a different length of time that it's effective. And, pick something that has a 12-hour time period. That may be what they're sort of designed for the general population, but some people need to take that a little bit more often. And so that may change depending on what your needs are. So some of it, again, is trial and error. You have to experiment with that. And talk about it with your doctor, though, because we sure don't want you taking more than you really can take. But your doctor may suggest, hey, certain times you can take extra so we can get you through the night.
That's great. Thanks, Pat. The next question, is it possible to build up a tolerance to any kind of medication dealing with the bladder?
Another great question, because this is common. I think that I don't know whether it's a tolerance or whether it's a change in the way that the bladder reacts to the medication. But I do find that patients who have done well on product X will come in again and say, this used to work really well, but it's not working so well now. And when they do that, then, we have that nice long list, and we can try something else. Or we can try increasing the amount of the medication, or we can try doing it more frequently. I mean, again, we're trying to work with each individual to find what's going to work best for them.
Great. The next question asks, is it possible to tell whether bladder problems are due to MS or menopause?
That is a frequently discussed issue. I think that no matter what the cause, you need to look into it, because just because you're going through menopause and you're having difficulty, what can happen with menopause is the tissue that lines your for you on the line who are women, the tissue that lines the vagina is the same tissue as what lines the urethra. So when your vagina, through menopause and after, has become thinner, and maybe that's because of lack of hormones and the aging process, all of that put together, when it becomes thinner, then the lining in the urethra does as well, and so you have a sense that you have to go to the bathroom more often. But of course, taking a history, you're telling us you're having to avoid more often. Yes, and this is part of what I would ask you, are you menopausal? And that gives me more information, but it doesn't tell me exactly what is the issue. So again, it's something worth asking the right people. So if you are menopausal and you think maybe it has to do with that, talk to your family doctor or your gynecologist and find out if that could be part of the problem. And if it's not that, then you may try some of the things, dealing with it as an MS issue, or you may want to see a urologist and sort of, have the full Monty when it comes to a workup. But it could be either one. And I don't think we know just by listening and talking which it is. I think we have to kind of explore that a little further.
Great. The next group of questions have to do with urinary tract infections. The first one is, are there easy at-home tests for UTIs? I've
heard this talked about a lot more recently, so there must have been something in a journal, or not a journal, but a magazine or something about this. There are what we call those dipsticks that you can put in. You put your urine in a cup and then put the stick in there, and it will show if there are indications of infections from that dipstick. But having so done that, then what do you do? And here's what the issue is with bladder infections and with that home testing. What patients have told me is that they do that, and then they call their doctor, and they tell their doctor that they've done this, and the doctor says, I'll call you in a prescription. And they'll call in whatever it is they call in. There's a problem with that. And the problem with that is that unless you have taken in a sample to the office and have it looked at in a laboratory setting, you don't know how much of an infection it is, and you also don't know what the organism is. And so whatever antibiotic is called into the pharmacy, it may help with that organism, or it may not. And so, if he calls in X and you don't have that organism, you have a different organism, then you can take X and you're not going to get better. And then you're running the risk of that infection getting worse. And so I have a problem with that. But, whatever works. And I'm hoping that if you're talking with your physician about this, then, the physician is going to talk to you about, other ways that you can handle this that maybe won't put you at risk. And maybe you and he can decide, okay, have her dip and we'll try this, and if after 1 day or 2 days it isn't any better, then she'll call me back and then we'll get it, whatever. So that's what I can tell you about that.
Great. And kind of along those same lines, what's the best way to avoid urinary tract infections?
Keeping fluids up is one way. Emptying your bladder as often as, if you tend to hold on to urine, emptying it more often will certainly help out with that. A lot of people, women especially, our urethras are so much shorter than men. And because they're shorter, they're more likely to get infected. The bladder's more likely to get infected. We see fewer bladder infections in men, and that's because their urethra is that much longer. And also, our urethra is right next to our rectum. And so, sometimes with poor habits, or you've had some diarrhea, whatever, you can get some of those bacteria. E. coli is a biggie that lives in our gut, and you can get that into the urethra, and that causes the infections. So how can you prevent it? Well, good toileting habits, keep up your fluids. Some women describe that after intercourse, they will have infections, and we call that postcoital infections, and that means after intercourse. And one way to manage that is to make sure that you empty your bladder right after intercourse, and that helps to wash out the urethra so that we get rid of some of those bacteria. And another way, after talking about this with your physician, sometimes women get this so often that, it kind of makes people want to stop and not want to have intercourse anymore. And so some doctors will automatically say, with intercourse, go ahead and take these antibiotics, and we'll give you just a few to take when you have intercourse. So those are some ideas.
That's great. And we just have time for a couple more quick questions. One is back to catheterization, and it asks, does intermittent catheterization affect the ability to become pregnant?
Actually, no, not in any way, shape, or form. The urethra is in front of, closer to your tummy than your vagina is. So they're not in any way connected, and so you can catheterize, but it's in no way going to get anywhere near your reproductive organs.
Great. And last question before we wrap up. How can you distinguish between a bladder issue and a sphincter issue?
You can't. As a person living with MS, you know what your symptoms are. But even I, as a healthcare provider, when you tell me your symptoms, I can't tell you what the problem is. I can only tell you what symptoms it's producing for you, and that's where we need to look into it more further so that we know exactly what the problem is, so we're not treating the wrong thing.
That is great. Great information, Pat. Thank you so much.
You're welcome.
Do you want to wrap up with any closing remarks?
Well, I just, again, want to encourage all of you not to live with this if this is a problem for you. Seek an answer. Will it be perfect? Maybe not. But will it be better? Almost probably will. So take this information, roll it around in your head, and then seek the help you need, whether, again, you start with your primary care, your gynecologist, or you go to a urologist. You want to manage this. And many neurologists, your MS doctor, are able to manage the basics, and then if things don't respond to that, they'll refer you on. But you don't have to suffer with this. So look into what other solutions you can try.
Great. Thank you so much. Just want to wrap up and say thank you to Novartis Pharmaceutical Companies for sponsoring this program. The next webinar is scheduled for November 9th, 2010 at the same time, 8 p.m. Eastern. And the topic is healthy eating and nutrition, and the presenter is Baldwin Sanders, CanDo MS Programs Consultant. You can register for the webinar at www.mscando.org. For those participating tonight live, as soon as the presentation is over, you will see a survey appear on your screen. And please take a moment to complete the survey and help us continue to improve this webinar series. We value your feedback and input. Thanks again, and have a great night.
Thanks, everyone.
Thank you. Please stand by.